Hi everybody, John Herzenberg here, and today I'm going to be demonstrating correction of this complex foot deformity. Let's call it a Charcot foot that's rigid. The hind foot is reasonably flexible. We can do a TAL if we need to get that in a good position, but the entire midfoot is in this dorsiflex position. You can measure it by drawing a line along the axis of the talus and axis of the first metatarsal. That's the Miri angle, which should be 0, and his instead measures 45 degrees. So it's 45 degrees apex volar. In addition, if we look at the calcaneus and the fifth metatarsal, that calcaneal fifth metatarsal angle should be 0, and here it measures, by my measurement here, 40 degrees of abductus, or 40 degrees of valgus. So it's a complex biplanar deformity. Since the hind foot is relatively normal here, I can do a TAL and put it into a normal position. We may start the procedure by doing a TAL if it's in a bit of equinus, and then lock it into this position. The frame that we're going to apply is a so-called butt frame. It's going to look something like this. And the term butt frame comes from the carpenter's term of a butt joint, where you have a 90-degree angle between two rings. So the U-ring in the back of the foot is the actual working ring. The other U-ring that's on the tibia is simply there for fixation purposes. But the working ring that we'll be connecting to is this vertical U-ring. And then we'll add a ring on the metatarsals here. And so all the action will be taking place between this ring and the posterior U-ring. And that will be the so-called butt frame. So I'm going to start by doing a TAL. I'll put a pin plantarly to pin the talus to the tibia in the position that I want it, and then I'll mount this U-ring on and the tibial fixation ring with a combination of wires and half pins. So I'm going to do that, and we'll be back in just a second after I've accomplished that first stage. I've applied the first part of the frame. This is the butt ring with a butt joint between the tibial fixation ring and the foot fixation ring. Both of these are 2/3 rings. You can use a full ring as the tibial ring, but it's convenient to use a U-shaped ring that's open in the back because we don't need anything closed in the back here. How did I apply this? Well, first of all, notice that the U-ring is parallel to the tibia, and the other U-ring is perpendicular to the tibia. We also started off by doing a tendo-Achilles lengthening so we can get the Achilles tendon and the calcaneus down into a normal neutral position. And I temporarily fixed the calcaneus, talus, and tibia with this plantar wire. That makes it easier to put the frame on because you don't have to wrestle with the ankle moving up and down. So we put the ankle in an anatomic position and then pin it. And so now the hind foot now is completely normal. And that's the purpose of the butt frame. It's when you have a midfoot, forefoot deformity, but your hind foot is normal. So we apply the hind foot frame to match the normal hind foot, and then we'll add the forefoot ring perpendicular to the metatarsals, and that will reflect our apex volar deformity. Fixation is quite simple. I've used counter-opposed olive wires, one from each side. I'm cognizant of where the neurovascular bundle is coming here, so we don't want to be anywhere near the neurovascular bundle. And then for my tibial fixation, I have a delta spread and at 2 different levels with a 1-hole cube and a 5-hole cube. I will warn you one thing about doing this in a diabetic. If you end your frame here with a half pin, there's a lot of strain on that half pin, and many patients will develop a stress fracture at that top pin. So when I'm treating diabetic patients who are insensate, I normally extend the frame up proximally and add a 2/3 ring or other ring up at the top so that we have a larger area of fixation and we're not concentrating the forces on the diaphysis. For purposes of this laboratory, we don't need to do that. I'll also state that in this type of malunion or Charcot joint, if it's rigid, I'll start by doing the osteotomy before I put my rings on. In this model, that's not going to work because there's no soft tissues to hold it together. But in a real foot, even after you do a complete osteotomy with a jiggly saw, for example, you'll not get a floppy foot. It'll stay more or less intact in its position due to the ligamentous structures circumferentially around it. But in this model, we're going to put the rest of the frame on, and then we'll do the osteotomy last. But in a clinical situation, I would do the osteotomy before I had any of the rings on. Our osteotomy is going to be through the navicular cuneiform fusion mass here, which is the apex of this deformity. The one last important point is when we do the osteotomy, I'm going to add one more wire just proximal to the osteotomy. If the osteotomy is here, I'll add the wire just proximal to that. And that's called a stirrup wire. It's going to be bent and then attached with posts to the hindfoot ring. And the purpose of that, and I'll add another one anterior to the osteotomy, so there'll be one in front and one behind. The purpose of that is to focus the forces of distraction on the osteotomy and not on all these little joints in the foot. So we want the distraction to occur through our osteotomy and not, for example, through the cuneiform first metatarsal joint or the talonavicular joint. All right, so next I'll be applying the forefoot ring. We'll be back in a minute just after I complete that stage. Now I've completed the forefoot fixation. So this is quite simple. I applied the forefoot ring, which is the reference ring, carefully so that it aligns with the axis of the forefoot. What do I mean by that? If we look from the side, the ring is perpendicular to the metatarsals because our planning will be based upon the metatarsal lines. And also from a rotational standpoint, if this is the front and back of the ring, that lines up with the middle of the foot. We haven't rotated the ring either direction. If you do, you just have to tell the computer you've done that. So in terms of the mounting parameters, what the computer wants to know is where did you put this ring on relative to the foot. And the 30 millimeter bolt here, and this white line represents the center of the ring, the equator of the ring, the other one is here. So if I take an x-ray and this bolt is superimposed with the one in the back, then we'll know that where the center of the ring is, and it looks to me like it's exactly on the metatarsals. So from an A to P direction, our mounting offset is 0. And looking from the front, the center of the ring, marked by these two 30 millimeter bolts, is also in the middle of the foot, which is defined as the second metatarsal. So we have basically a center mounted ring. Our mounting parameters will be 0. The computer will want to know how far this ring is from the apex of the deformity and subsequently to the origin. So the next step is going to be to put the struts in. Once I have the struts in and I've measured their lengths and sizes, I'll remove a few of them to do the osteotomy. And we'll just want to point out that I will add another wire just behind the osteotomy and just in front of the osteotomy, so-called stirrup wires, to focus the force of the distraction on the osteotomy. This stirrup wire will attach to the forefoot ring. This stirrup wire will attach to the hindfoot ring. I've added the 6 hexapod struts. How do we label them? Well, one of the rules that's an absolute rigid rule regarding this system is that even if we're using a distal reference, the master tab is always on the proximal ring. So this is our proximal ring, this is our distal ring. The master tab by definition is where strut number 1 and number 2 come together. Now, the thing that's confusing is we're used to seeing the master tab in the front, and now we're seeing it in the back. So we have to talk about that and think about it for a minute. So I'm going to take a 2/3 ring and do a little demonstration of how this works. So the trick or the little mnemonic for remembering where to put the number 1 and number 2 strut, we all know where to put it if this is say a Blount's frame or a tibial frame. This will be the master tab, and the number 1 and number 2 would go here, and they are moving around counterclockwise from the bird's eye view. So I'm going to put my finger in the hole where the number 1 strut would go. And what you have to think is that this U-ring started out life up here as a proximal tibial ring. But what happened, and remember my finger is in the number 1 hole strut. 1, 2, 3, 4, so forth. So what happened to get to the foot, it first did a 180-degree turn and then slid down the leg. And so now look where my finger is. My finger is in where the number 1 hole, number 1 strut is. And so this lateral hole, this is the 5th metatarsal, the lateral hole is the number 1 strut. So that's how I've labeled this number 1, number 2. 1 and 2 come together on the master tab in the proximal ring, so we're following all the rules. And then it keeps going around counterclockwise, 3, 4, 5, and 6. So the way that Charlie Taylor used to teach this was that you think of this as your 1 and 2 struts here as pulling a sock down and rotating it around 180 degrees. And so then you get a 180-degree offset. So it started life up here, made a 180-degree turn, and slid down the leg like a sock coming off the leg. And so when we program the computer, we have to tell it that we put this frame on with a 180-degree rotary frame offset, so that our number 1 and 2 struts, our master tab, is posterior instead of the usual anterior place. So next, what I'm going to do, I'm recording the strut lengths and sizes. And so we put them down on this card, and I can take that to the computer and plug in the numbers. I know all the lengths of the struts, the size of the rings. And I even put down that we have a 180-degree rotary frame offset. Next, what I'm going to do is I'm going to do the osteotomy. So for that, I'll take out some of the struts that are in the way. I'll be able to put them back in their orthotopic positions because I know what their lengths and their sizes are. So at this point, our osteotomy is complete. Actuality, for a real clinical case, I would do the osteotomy first. And I would also put in the stirrup wires first, but for practical reasons in the Sawbones lab, it's best to do it after you put the frame on. So there's our complete osteotomy through the cuneiforms and the cuboid. And notice that the stirrup wires that I've inserted, and I've already bent them 90 degrees, they've been put on either side straddling the osteotomy, and the distal wire will be bent backwards or down to attach to the metatarsal ring. The proximal wire will be bent posterior and attached to the hindfoot ring. And that will focus the forces on this osteotomy. And that ensures that the osteotomy will distract rather than seeing distraction through the small midfoot joints. So I'm going to go hook this back up again, and then we'll take a look at the final frame. So this is our completed frame. The proximal ring, which is a U-ring, the distal ring, which is a full ring, that's our reference ring, and the master tab is on the proximal ring. It's where the 1 and 2 strut come together. We said already that this is a 180-degree rotary frame offset, so we have to put that information in the computer. The osteotomy is done through this midfoot fusion mass, and I've added a stirrup wire. Why do we call them stirrup wires? They're kind of like the stirrup of a horse, where they're not tensioned, but they're just bent 90 degrees just outside the skin and then attached. And I think if we look at it from the plantar surface here, we see that a little bit better. So we can see the osteotomy. And then just on either side of the osteotomy is a stirrup wire that's bent 90 degrees. The proximal one is bent and attached to the proximal ring, and the distal run is bent and attached to the metatarsal ring. On the other side, we could see the osteotomy, and on either side of the osteotomy, a stirrup wire, one of them bent and attached proximally, the other one bent and attached distally. Now when these stirrup wires are attached, you just bend them over the ring and attach them, or you can attach them to a post as shown here. And once again, these are not tension wires, but they do focus the force of distraction on the osteotomy, and hopefully that'll make our osteotomy open instead of the small joints of the midfoot or the talonavicular joint or calcaneocuboid joint. So that's our completed frame. Take the frame upstairs to the X-ray department. We'll get our official mounting parameters. And to get the mounting parameters, I'll add these markers where the equator line is. Although I can already tell just from looking at this that our reference is basically 0, 0. We're not displaced above or below the metatarsals, and we're not medial or lateral to the metatarsals. And now we're going to take a look at the post-operative x-rays. So first on the left you see a lateral view, and I took the x-ray centered on the reference ring. The reference ring is this distal metatarsal ring. So the ring is nearly in profile, overlapped, and it's applied perpendicular to the metatarsals. If that's the reference line, where's the moving line? And the moving line is the line representing the long axis of the talus. So this is the Meary's angle, and what we're after is a Meary's angle of 0, but instead what we have here is a 45-degree Meary angle. So we have 45-degree deformity, apex volar or plantar, and the intersection between the yellow line, which is the talar body and neckline, versus the metatarsal line is the apex of the deformity, and we're using the planning method known as apex equals the corresponding point. So if that's the corresponding point, the origin is somewhere on this red reference line, and since we have to disengage this a centimeter or two, I'm going to move this yellow circle about a centimeter or two away from the apex, and that will become the origin. So the origin is always on the reference line. The corresponding point is always on the moving line, and in this method known as the apex equals corresponding point method, the two of them end up being on the same line, so it minimizes the translations. So one of the things the computer wants to know is how far is this origin from the reference ring, and we can simply measure that on the x-ray. Here it's about 80 millimeters. And if we look at the AP view that I took of the foot, we can see that the center of the ring, which is measured by these two long posts here, these long bolts, not 100% overlapped here, but if we go somewhere in between, we can see that the center of the ring here is centered around the middle of the second, or next to the second toe. So it's fair to say that the metatarsal ring is centered both on the AP view, and also it's centered on the lateral view, because this long bolt is the middle of the ring. There's two of them overlapping here. So we have our mounting parameters are 0 on the lateral view and 0 on the AP view. One more x-ray view of the AP foot shows what the deformity is in the AP view. The red line is drawn along the wall of the calcaneus, the lateral wall of the calcaneus, and the yellow line is drawn along the fifth metatarsal. So this angle should be 0, but in this case we have an abduction deformity, or valgus deformity, of 35 degrees in this case. Now we'll take this data and go to the computer and come up with our program for this butt frame diabetic foot which has an apex plantar and medial deformity. This is the first of 7 screens, and I've put in some basic demographic data here. This is a butt frame, a diabetic foot, the date that I did the correction, and this is just some notes that I put in for myself: 45 degrees apex volar or plantar and 35 degrees of abductus. And we're using a 6x6 butt frame, and we can tell the computer that it's on the left foot and the osteotomy is in the midfoot. And 99% of the programs that we do are total residual. Chronic refers to when you're building a frame ahead of time. Now we're on the second panel, and it asks us to select a reference fragment. So we selected distal. That's usually how we do butt frames. We apply the distal ring on the metatarsals. So that's our frame of reference. And so if that's the frame of reference, it's the world according to the metatarsals. And so the metatarsals are applied flat, and the rest of the foot above it is off axis. So I've inserted the numbers that we measured, 35 degrees of valgus and the AP view, and 45 degrees of apex plantar deviation on the lateral view. And I also added that it was short. And initially I did this program, I put in about 15 millimeters short, and that wasn't enough to disengage. So I went back and redid this with 26 millimeters short. So we're really going to have to pull this apart to get it to not impact on itself and impinge during the correction. So once I put in these parameters, then the computer draws these images. We'll go on now to step 3, which is the frame. Here we've used, for the proximal ring, a U-ring, 155 millimeters, and for the distal ring, 130 millimeter full ring. And then the struts that we inserted were all mediums except for strut number 5, which was a short strut. That's pretty straightforward. Now we'll go on to the next step. This is the mounting parameters. And you recall that on the AP X-ray, our reference ring was centered on the metatarsals, so there was no offsets, either medial or lateral. And on the lateral view, our ring was also centered on the first metatarsal. So again, there's neither dorsal nor plantar translation of the ring. The ring is perfectly centered on the metatarsals. However, I did point out to you that in our planning, the ring was put on 80 millimeters distal to the origin. And we did talk about this concept of a rotary frame offset. With all butt frames, we put them on with a 180-degree rotary frame offset. And so this is our chance to put that in the program and tell the program that we did put the ring on in that flipped direction. Now we'll move on to the strut settings. In this panel, we're asked to insert the starting numbers of strut 1, 2, 3, 4, 5, and 6. And then once those are inserted, you press on the calculate button, and the computer will chug along for a bit and then populate the final strut settings. This is telling you where we're headed. So we're starting up here at the initial strut settings, and we're going to these final strut settings. And I've chosen to depict the lateral view. This is at the beginning, and this is after it's corrected. So at the beginning, we have a reverse Meary's angle. At the end, our Meary's angle has been corrected. Now we're on panel number 6, which asks us to define a structure at risk. The structure at risk is that part of the bony or soft tissue anatomy that we determine has to move the fastest. So in this case, it's the on the AP view, since we have abduction, it's the concave portion, so it's lateral to the origin. The origin is that reference line in the middle of the foot that goes along the second metatarsal. And from that measured to the lateral board of the foot, I estimated here is about 22 millimeters. On the lateral view, we're looking at the structure going the fastest as this dorsal cortex, and that's about 12 millimeters above the middle of the bone. So I put that in. These numbers you can just estimate or you can measure as you like. And then the axial view is where is it relative to the origin. And since our origin was a bit proximal because we did the apex equals corresponding point method, we'll move a little bit distal to the osteotomy, about 10 millimeters. Now the next thing, this is very important, it wants us to enter the maximum safe distraction rate. And this is very typically 1 millimeter per day. But here, in this case example, I put in 5 millimeters a day, and I did it specifically so that we would correct quickly. And you'll see why in the next panel. If I had put in 1 millimeter a day, this may have taken 25 or 30 days to correct, but if I put in 5 millimeters per day, we can correct the whole thing in 9 days. So let's do that, and we'll advance to panel 7. This is the final panel in which we see the actual schedule that is going to the patient. And so because I've done it very quickly, we finished the entire program in 9 days, and this all shows up nicely on a single slide. So this is our day 0 where we start, and the final day of correction, day 9. These colored blocks indicate struts that have to be changed. Interestingly, strut number 5 has to be changed twice, strut number 6 changed, and strut number 4. And down here you can see what the struts have to be changed. So strut number 4, for example, starts as a medium and then becomes a long. So at this point, I'm going to take this schedule back to the lab, and I'm going to do these strut changes and put all these final numbers in, and we'll see what our model looks like when I've done all that. So I've just returned from the radiology suite where we took our x-rays, put in all the mounting parameters, deformity parameters, structure at risk parameters into the computerized program, and then came up with a solution. Because this was a big deformity correction, I programmed in about 2 centimeters of lengthening. Why? Well, if you can see at the osteotomy site, we're touching here on the medial side, but we have a couple centimeters of distraction on the lateral side. So it's a big correction, but in the end, our calcaneal 5th metatarsal angle has been restored, and the Meary's angle, the talo 1st metatarsal angle, has been restored. It looks like a foot now. It's plantigrade and should be serviceable. I'll point out a few things about the frame. I have a long exposed segment of tibia, and in a diabetic patient such as this one that had, we're saying has a Charcot midfoot, having a lone pin in the middle of the tibia here is not such a good idea. So if this was truly one of a diabetic patient, I would add another ring a little bit higher up so that I could have pin fixation or wire fixation up here and not have this as a stress riser in the middle of the diaphysis. If you leave this, this can lead to a fracture. I also point out that for big corrections, you can get additional fixation by putting in longitudinal wires in the foot, and you could add a half ring or a plate to attach those wires, and that gives you additional fixation. Fixation that we currently have in the midfoot consists of these 2 wires. One wire is in metatarsal number 1 and 2. The other one is in 5, 4, 3, and 2. So we're grabbing with these oblique wires all 5 metatarsals, and then we also have the stirrup wire just distal to the osteotomy. So if you like, you can add additional fixation for additional stability. You can add longitudinal wires as required. And that concludes the butt frame laboratory. Why butt frame? Because this is a carpenter butt joint where a 90-degree angle occurs between 2 rings. Thank you very much.